Yes, so we are live.
Okay. Good evening, everyone. Myself, Dr. Sourabh Kiste, and a very warm welcome to the 35th edition of Nephrocon.
Thank you.
Today's session focuses on 2025 KDIGO Guidelines on the management of anemia in the patients with CKD. What's new and what is not. So this is an area central to everyday nephrology practice, especially with evolving data on if PHIs, iron strategies, and hemoglobin targets. So we are privileged to have with us our speaker for the evening, Dr. Sourabh Sharma, who is an associate professor, Department of Nephrology at Safdarjung Hospital, New Delhi. We will also be joined by our esteemed panelist, Dr. Deodatt Chafekar, who is a director and senior consultant nephrologist at Supreme Kidney Care, Nashik, and Dr. Shital Langade. He is a senior nephrologist at RG Urology and Laparoscopic Hospital, Goa. So we look forward to a highly interactive and insightful discussion. We also acknowledge and thank Acognos for their support in facilitating this academic session. With that, I invite Dr. Sourabh Sharma to begin his presentation.
Thank you very much, sir, for the kind introduction. So first of all, I would like to thank the Nephrocon organizing committee, Dr. Girish, sir, for giving this opportunity. So the today's topic is on 2025 KDIGO Guidelines, and it's regarding what's new and what is not as compared to the previous guidelines which were published a decade back. So as we all know, anemia is a frequent complication, and it is one of the four major complications of CKD, which we deal with in our everyday practice in ward as well as in OPD patients, as well as in dialysis unit. And it's often difficult to treat. And it is associated with the reduced quality of life, increased hospitalization rates. There is increased other complication risk also as compared to the CV complications, and there is increased morbidity as well as the mortality of CKD patients suffering from anemia. So development of anemia in CKD, it is multifactorial. So there can be EPO deficiency or hyporesponsiveness. It can be because of iron deficiency, because of blood loss. So these three are the most important factors which cause anemia in CKD. And apart from that, it can be because of the reduced RBC lifespan, because of the endocrine disorders, bone marrow suppression, nutritional deficiencies, chronic inflammation, and genetic conditions. So why was an update needed? So as we all know, the last update was in 2012 and then in 2025. So in the past decade, there were advances in the understanding the CKD-related anemia, and there was novel therapies which were introduced, including the hypoxia-inducible factor chloryl hydroxylase inhibitors, and they were updated iron protocols also. And it's all required guideline revision. And now in the present guideline, there has been a focus upon the optimization of individualized therapy and improving the cardiovascular and hematological outcomes in patients of CKD suffering from anemia. So as compared to the previous guideline, there has been a major conceptual shift. So from uniform protocol, which was there in 2012 guidelines, now it's more towards a precision medicine. So in 2025 guidelines, they emphasize on individualized, risk-adapted therapeutic strategies. And here we have a refined hemoglobin protocols and patient-specific goals have been defined. So management now is tailored based upon the CKD stage, as well as the other comorbidities and the dynamic treatment response of the patient to the therapy. So it reflects a broader integration of precision medicine into nephrology. So definition of anemia, it stays unchanged as compared to previous guideline. In men, it is hemoglobin less than 13. In women, it is less than 12 gram per deciliter. And in pediatric patients, it is still determined using the age-specific hemoglobin cutoffs, reflecting the physiological variation across the developmental stages. And the newer guidelines, they place the greater emphasis on comprehensive evaluation to identify the underlying causes once anemia is detected, rather than attributing it solely to CKD. So regarding diagnosis and evaluation in the present guidelines, As we can see here on the right hand side, so now the for evaluation for anemia in patients suffering from CKD, evaluation should begin at referral, during the follow-up, and whenever symptoms suggesting anemia appear. So after we have started the working upon the evaluation for anemia, the severe iron deficiency has also been defined in the present guidelines. As per it, if the ferritin level is less than 45, they say it is severe iron deficiency. And if there is clinical judgment also and ferritin level is less than 100 and there is a like major symptoms are there, then also we can define it as severe iron deficiency. If ferritin is not available, then also we can define severe iron deficiency. If there is a profound iron deficiency because of microcytic anemia, MCV is less than 80 femoliter, and there is absence of any other genetic cause, including thalassemia or sickle cell anemia. So in these cases, we define it as severe iron deficiencies. And here, as per the guideline, we should refer these patients with severe iron deficiency to rule out the bleeding. So as per the source of bleeding, we should refer to urology, gynecology, gastroenterology as per the source of bleeding. So if there is no severe deficiency and we have found that the patient is suffering from iron deficiency, and then we can just go on, move on by replacing the iron. But if the iron deficiency is not there, now the guidelines say that there should be an battery of investigations through which the patient should undergo whenever there is no iron deficiency, which includes blood smear as well as CRP to rule out inflammation, B12 folate, serum LDH, liver enzymes, serum protein electrophoresis, TSH, and stool analysis. So these are the battery of investigations after the initial laboratory panel, which is suggestive of that no iron deficiency is there. So now the new guidelines, they encourage broader etiological evaluation as compared to the older guidelines. And as per the new guideline, anemia in CKD is no longer assumed to be renal, and it pushes clinicians to actively exclude the reversible causes before labeling it as CKD-related anemia. Now, the anemia testing and further evaluation as per the KDIGO guidelines. So in stage 3, the frequency of anemia testing should be yearly. In stage 4, it should be twice a year. And in stage 5 and stage 5 on dialysis, it should be every 3 months. And there are many circumstances as per the new guidelines which warrant more frequent iron testing. And these are the initiation of or increase in dose of ESA or HIF-PHI is there. If there is episodes of known blood loss, there is recent hospitalization, or if there is important increase in ferritin or TSAT, or there is overshooting target limit, then we should have more frequent iron testing. So here it mentions the battery of investigations when the iron deficiency is not there. And if there is severe iron deficiency, then we should be referring to the gastroenterologist, gynecologist, or urologist as per the source of blood loss. So what is new in diagnosis part in KDIGO 25 guidelines? So now there is more structured diagnostic framework. There is clearer guidance on both initial and additional testing. There is an expanded laboratory assessment. Apart from iron deficiency, the other causes would be ruled out. There is better identification of iron deficiency. Now they have split the ferritin and TSH levels as per the patient profile that we will see in the coming slides. And also there is it suggests early investigation for occult blood loss, early referral for occult blood loss, and referral whenever there is severe iron deficiency. So these are the new things which have been incorporated in the new guidelines. So the key updates from iron therapy: we should optimize the iron status and treat inflammation before initiating the ESA therapy. We should start iron even in profound deficiency without anemia to prevent its development. So profound deficiency, they say that when ferritin is less than 30, then it is profound iron deficiency. And here, even if the anemia is not there, hemoglobin is above 12 and 13 gram in men and women, then also we should start give iron therapy. And we should switch to IV iron from oral therapy if the oral therapy fails after 1 to 3 months. So it is more specific in that regard also. And monitoring part, every 3 months when non-dialysis and PD patients, and in dialysis patients, monthly monitoring they have advised. So the biggest shift in treating iron deficiency is that we should be more aggressive in treating it. And there is earlier positioning iron not just as supportive therapy but as cornerstone of anemia management in CKD. So what are the considerations for selecting the oral versus iron therapy? The KDIGO 2025 guidelines, it says that we should be it should be a patient-centric approach. And while giving oral or IV iron, we should start discussing with the patient also. We should start discussing about the efficacy, that the IV iron, there is more rapid increase in hemoglobin, ferritin, and TSAT, and slower increase with hemoglobin, ferritin, TSAT with oral iron. And the side effects are less frequent and more severe if they appear in IV iron, and they are more frequent and less severe with oral iron. And it is more expensive, the IV iron therapy, and the oral iron therapy is less expensive. The accessibility, it is if the patient is near to the tertiary care center, IV iron is more accessible. It is less accessible in the periphery centers where oral iron is more accessible. And the impact of on the hemodialysis vascular access also should be taken care of. If the patient needs the preservation of veins because of the fistula creation in the near future, then oral iron is preferable. And according to adherence, if there is poor adherence, then we can give IV iron and then send the patient home. And also the suitability, we should, if there is a oral iron absorption is lower because of severe deficiencies, in that case we should start IV iron. So these considerations should be taken care of, and we should discuss with our patient regarding these considerations to switch between oral and IV iron. So what are the recommendations for the iron formulations? So as per the recommendations of KDIGO 25, in patients with anemia and CKD not receiving dialysis, whom iron needs to be initiated, we can give either oral or IV iron depending on the personal preference of the patient. So now it is a patient-centric approach. In those patients with anemia and CKD undergoing hemodialysis, stage 5D, here iron therapy is recommended if ferritin is less than 500 and transfusion saturation is less than 30%. So it is as per the previous guidelines. But in anemia with CKD, in which the patient is not on dialysis or patient is on peritoneal dialysis, now there is a newer consideration here, and they recommend that iron therapy should be started when ferritin level is less than 100, transfusion saturation is less than 40%, or if the ferritin level is 100 to 300 and saturation is less than 25%. So either of both. So here we should start oral or IV iron as per the patient preference. And here we can see the various oral iron therapies that has been suggested by the KDIGO 25 guidelines. And the ferric citrate has been included, where the elemental iron per tablet is 210 milligram. And in patients who are not receiving dialysis, one tablet can be given thrice a day. And those on dialysis, two tablets thrice a day has been recommended. So as per KDIGO 25, patients not receiving dialysis, these ferric citrate, it helps with phosphate binding as a secondary effect, secondary to the iron replacement. And those on dialysis, it acts as a phosphate binder with iron supplementary as the additional effect. So its role changes in those on dialysis, those not on dialysis. So ferric citrate has been included, and other formulations have clearly been mentioned, that liposomal iron, heme iron polypeptide, and the ferrous gluconate, they have less GI side effects and better bioavailability as compared to the other formulations. And as we can see, as compared, if we see the patient adherence, then the liposomal irons only one tablet once a day is required. So there will be more adherence with this formulation. Then, if the patient is having CKD stage 5D, patient is on dialysis and is having anemia, then as per KDIGO 25, IV iron is preferable over the oral iron. And the various IV iron formulations, the iron sucrose, they say that for people with CKD stage 1 to stage 5, not receiving dialysis, 1000 milligram cannot be given at a single setting. 5 doses of 200 milligram over 5 weeks should be given. So 1 dose every week. So 5 weeks dose is given for iron sucrose, which is most commonly available in the periphery centers. And coming to ferric carboxyl maltose and iron isomaltosite, they say that 1000 milligram can be given but the minimum infusion time for maximum dose is 15 minutes for FCM and 20 minutes for iron isomaltosite. And they say that full dose can be given in 1 or 2 settings in ferric carboxymaltose, because and we should be cautious about hypophosphatemia when giving in CKD and those on transplantation. And iron isomaltosite, full dose can be given in a single setting. And same is for ferromaxitol also. Also, the newer guidelines, they have suggested about the adverse drug reactions with IV iron therapy. So whenever there is a non-specific symptoms, we should stop infusion and we should restart after 25 to 50 at 25 to 50% rate after 15 minutes. And if there is mild infusion reaction, we should stop infusion, observe the patient, and retrial can be attempted after steroid and oral H1 blockers, one over after the treatment. If there is moderate reaction, we should stop the infusion, give IV iron, IV fluids, IV steroid, 100 milligram hydrocortisone, H1 blocker should be given, and we should consider alternative iron preparation based on the benefit versus risk. And if there is severe reaction, then we should avoid future IV iron totally. So they have clearly mentioned the adverse reaction with IV iron and how to manage. So in iron therapy, what is different as compared to 2012? So there is stronger emphasis on iron as first line optimization, and they have there is now a clearer biochemical criterion for the iron deficiency in non-dialysis patient and those on dialysis, those on peritoneal dialysis. So there is a more precise stage-specific diagnostic approach than the earlier guidance. And also there is a preference for IV iron in those who, as per the patient profile, as per the patient preference, and those on dialysis. There is higher dose strategies has been supported by the evidence. We can target higher ferritin with IV iron, which improves hemoglobin and clinical outcomes without safety concerns. And structured monitoring for safety and dose adjustment has been suggested in the newer guidelines. Now coming to the ESA therapy. So the ESAs in 2025 guidelines also, they remain the cornerstone therapy. And there is a clear guidance on initiation threshold in the 25 guideline as compared to 2012. And here they mention that in those on dialysis, ESA therapy should be suggested when hemoglobin is less than 9 or 10 gram per deciliter, balancing the benefits with a CV risk. Also, there has been a shift towards individualized treatment decisions here, and there is a greater caution regarding the safety profile, regarding the hypertension, thromboembolic events, and the cardiovascular complications. This has been clearly mentioned in these guidelines. And also there is a structured approach now for the ESA hyporesponsiveness. So the KDIGO 25 guidelines, they do not replace ESAs, but it refines their use by promoting safer thresholds, individualized decisions, and evaluation before dose escalation. So as per the 25 guidelines, in patients with anemia with CKD receiving ESA treatment, initial dose should be based on the hemoglobin level, avoiding the body weight and the clinical condition. So we can see here, if we talk about erythropoietin or darbepoetin or the Mircera, then the initial dose in those not receiving dialysis, now they say that 10,000 unit of EPO can also be given. So 4,000 or 10,000 unit weekly or every 2 weeks. In those not receiving dialysis, those receiving dialysis, it should be 50 to 100 unit per kg thrice weekly. Regarding darbepoetin, they say 40 to 100 microgram every 2 to 4 weeks. So now they say that darbepoetin can be given 4 weekly also. Similarly, Mircera can be given 50 to 120 microgram every 2 weeks or 120 to 200 microgram every month. And those on dialysis, the darbepoetin is 0.45 microgram per kg body weight weekly or 0.75 microgram per kg body weight every 2 weeks. And the Mircera, it is 0.6 microgram per kg every 2 weeks. Also, it mentions that in patients with anemia and CKD on ESA treatment, we should adjust the dose not more than once every 4 weeks, unless the hemoglobin rises by more than 1 gram per deciliter in 2 to 4 weeks, in which case we should reduce the dose by 25 to 50%. And we should administer ESAs with the lowest dose possible, which achieves and maintain the treatment goals. So they have mentioned that we should escalate or de-escalate as per the patient profile and for the patient safety, for the cardiovascular and thromboembolic events. So in the new guidelines, there also has been mentioned the framework for ESA hyporesponsiveness. So patients requiring escalating ESA doses are now classified as high-risk patients. And here they say that we should evaluate these cases, these patients for causes like inflammation, iron deficiency, and bone marrow dysfunction. So we should be more proactive in those patients who require dose escalation of ESA. And instead of dose escalation, we should consider iron optimization and HIF-PHIs in these cases. So most practical advances in 25 guideline is move from increase the ESA dose to stop and investigate why it is not working. So this reduces the harm and promotes smarter anemia management. So for ESA hyperresponsiveness, there is a clear framework now in 2025 guidelines. They say that patient with hyperresponsiveness to ESA, we should identify and treat the potentially reversible causes of anemia. If the causes are not identified, but hyperresponsiveness improves, we should continue monitoring. In those patients where cause is identified, but no improvement in hyperresponsiveness is there, or cause is not identified, but hyperresponsiveness persists, in these cases, anemia should be we should see what are the patient's symptoms and what is the category of anemia, what is the severity of anemia. If the anemia is mild and there are no symptoms, anemia related symptoms, then we should continue monitoring. If anemia is severe and symptoms are there, in these cases we should give a 3 to 4 month trial of HIF PHI and or transfusion if needed. So the major addition in 25 guidelines is of HIF PHIs. They have recommended HIF PHI as alternative in patients with ESA resistance or high ESA risk. So high ESA risk are those patients with like cardiovascular events, major cardiovascular events, or there is a vascular thrombosis, or there is a like in patients with malignancy, or those patients where there is a higher dose of ESA has to be given. So in these patients, HIF PHI is the substitute, and decision should involve shared decision making, considering the symptoms, risks, and prevention and the preferences of the patient. So here also it is the KDIGO guidelines say that we should be patient centric only, and we should discuss with the patient regarding HIF PHIs versus ESA. But they have said that we should avoid HIF PHI in high risk patients. So there are many HIF PHIs that has been enumerated in the guidelines, but in India the availability is of desidustat, and here they say that we should start with dose of minimum dose is 100 milligram. So below 100 they have not recommended, and maximum dose is 150 milligram thrice a week. So there have been they have given considerations for patients with anemia and CKD at risk for adverse events while starting HIF PHI therapy. So these are the 5 causes where we should not start HIF PHI in patients with active cancer, with a history of cancer not in complete remission for at least 2 to 5 years. Here we should not start. In polycystic kidney disease, we should not start. If there is proliferative retinal disease, we should not start. In pulmonary arterial hypertension and pregnancy, we should not be starting HIF PHI. Then there is a we should have a risk benefit analysis in those patients where prior CV event is there, prior thromboembolic event is there, prior vascular access thrombosis is there is hepatic impairment, or there is seizures, exfoliative dermatitis, hypothyroidism, bacterial infections in roxadustat. So here there should be risk benefit analysis, and in patients with post transplantation and in pediatric patients there is insufficient data and more research is needed. That is what KDIGO 25 guidelines mention. So coming to the transfusion strategy, so as per KDIGO 25 guidelines, there is a restrictive transfusion approach, which is as per the 2012 guidelines also, and decision should be symptom driven, not hemoglobin alone. And the typical trigger range remains low, 7 to 8 gram per deciliter, or severe symptoms are there. And the major risks which necessitate the caution is alloimmunization, iron overload, volume overload, or there is increased risk of transplant sensitization. So primary goal for transfusions in patients with CKD and severe anemia is to avoid whenever there is possibility of optimizing the iron therapy or ESA use and improving the long-term outcomes, especially in the transplant candidates. So KDIGO continues to treat transfusion as a rescue therapy as to the 2012 guidelines and not as a strategy for chronic anemia management. So here is an algorithm which has been made as per the KDIGO guidelines. So if there is acute clinical situations, whenever there is acute hemorrhage, there is unstable coronary artery disease, there is a rapid preoperative hemoglobin correction is required. Here we should have a risk-benefit ratio analysis and ruling out the potential harms, and we can give the transfusion therapy. But in the chronic clinical situations, we should look whether there is potential risk of ESA or iron therapy. It overweighs the benefit, or if there is a the ESA maximum dose has been given in those patients, we can give after a careful risk analysis. But patient those who are awaiting transplantation, we should not be transfusing, and only transfusing whenever there is severe symptom and hemoglobin is below a level and patient the risk is overweighing the benefits. So what is not new in the 2025 guidelines? So the definition of anemia is same. The role of ESA is the primary. It is same. The treatment goals. So the focus remains on improving the symptoms, quality of life, and limiting the transfusion exposure. That is the same as per the 2012 guidelines. And there is a restrictive transfusion strategy. And the foundation of care, the core management continues to rely on iron optimization, ESA therapy, and careful risk-benefit assessment. So the 25 guidelines is an evolution only. It is not a replacement of the 2012 guidelines. So side-by-side comparison of 12 and 25 guidelines. So these are my last two slides. So the overall treatment philosophy, there is a shift from precision towards the precision medicine. So more patient-centric care is advocated in 25 guidelines. The definition of anemia, it remains same. The diagnostic evaluation, they have battery of investigations which have been suggested in those who have no iron deficiency. It encourages search for reversible causes and reduce the inappropriate ESA use in these patients. And the iron therapy strategy, it prioritizes iron optimization and inflammation control before the ESA initiation. So we can lower the ESA dose requirements and the complications related to the higher ESA dose. And iron in non-anemic deficiency patients, we can consider iron therapy in profound deficiency even without anemia. So here we can actually be preventing anemia development in next few months. So even those patients who have no anemia and there is profound deficiency with ferritin less than 30, we should give oral iron replacement. Then iron monitoring, they say that every 3 months in non-dialysis and PD patients and monthly in HD patients. So it promotes tighter safety surveillance also. Regarding ESA therapy, it remains first line. And for ESA initiation, now they suggest that hemoglobin is less than 9 to 10 in dialysis patients, then we should start ESA. And now it has a clearer initiation guidance also. Regarding hyporesponsiveness, they have a clear framework and clear protocol how to manage the hyporesponsiveness, so we can prevent the harmful dose escalation in these patients. And now there is a incorporation of HIF PHI, so there is a therapeutic expansion in that regard. And regarding HIF PHI safety also, there are guidelines when not to use, when to be have a risk analysis, and it encourages cautious patient selection in these patients who are being started on HIF PHI. And then the KDIGO 25 guidelines, it advocates shared decision making. So now it is patient centric. We should be the patient should be equally involved in decision making, and treatment initiation should consider the symptoms, risks, and the patient preference. And regarding transfusion strategy, largely it stays unchanged. Regarding the guideline structure, it adds the practical points now, the practice points, and improves the real world usability of the guidelines. And it has better tailored clinical decisions have been advocated in 25 guidelines. So the take-home messages are that KDIGO 25, it represents a major evolution building upon 2012 guidelines with more precise and individualized strategies. Biggest changes are the precision medicine approach, HIF PHI integration, and structured ESA management. The core principles, it remains intact. So KDIGO 25 represents an evolution rather than a paradigm shift. And it strongly promotes individualized and patient-centric care, and iron optimization and structured evaluation of ESA responsiveness has been emphasized. And introduction of HIF PHI, it expands the therapeutic landscape of anemia and CKD. And overall, the 25 guidelines, it moves the anemia management towards a precision nephrology, safer, earlier, and more tailored interventions for patients with CKD. Thank you very much.
Thank you, sir. Thank you very much. It was quite a comprehensive overview of our 2025 Anemia CKD guidelines. Thank you very much. I'll move forward. Now we'll move into the panel discussion. Shall we, Girish sir?
So, Seema ji, can you share the questions now?
Sure, sir.
Sourabh, that was an excellent talk. I must appreciate.
Thank you, sir. Thank you very much, sir.
So now we'll begin with the panel discussion. I'll start with questions to Sourabh sir only. So my first question is, now use of oral iron supplements is debated for use in patients with advanced CKD, especially for individuals on maintenance hemodialysis. How useful are oral heme polypeptide in patients with iron deficiency and advanced CKD as a maintenance therapy?
So, as you all know, the oral iron therapy, it has traditionally it has been less favored in advanced CKD, particularly in patients on maintenance dialysis. And primarily it is because of poor absorption, and there is inflammation driven functional iron deficiency, and there is GI intolerance. So heme iron polypeptide, it was introduced to improve the bioavailability compared with the conventional oral formulations. But the real world data and the comparative trials that have been shown in the previous last decade, it has shown that it does not consistently match the efficacy of the IV iron in terms of the transferrin saturation, the serum ferritin, and the rise in hemoglobin in the dialysis populations particularly. So in my practice, I would view oral heme iron as a niche option rather than a maintenance therapy, and particularly it can be useful in early CKD in patients who are refusing IV therapy and those with limited IV access, or there is a resource constraint settings. In those cases, we can have this formulation. But for most patients on chronic hemodialysis, the IV iron remains the standard of care as it is more predictable and aligns with the contemporary guideline direction, emphasizing the oral iron optimization.
Excellent, sir. And with considering our patients, I think compliance also matters, and IV
Yes.
iron definitely becomes more compliant therapy. We are more satisfied that at least patient has received some iron therapy.
Yes, sir.
Coming to second question, so would you recommend combination of HIF-PHS and EPO in the management of CKD anemia at any stage, particularly in stage 5?
So, as per the guidelines, 25 guidelines, and also as per the different trials which have been come upon in last few years, so as per them, I do not recommend routine combination therapy with HIF, PHI, and erythropoietin. So both HIF, PHI, and EPO, they simulate erythropoiesis through overlapping physiological pathways. So ESAs, they act directly, while the HIF, PHI, they enhance the endogenous erythropoietin production and improve the iron utilization. So using them together may increase the risk of excessive hemoglobin rise. They can increase the risk of hypertension, thrombotic events, and there is no clear evidence also. So the current treatment philosophy is moving towards a therapeutic substitution rather than the combination of both. So we typically choose one strategy based on the patient characteristics, as the 25 guidelines also mention. But the combination therapy still can be explored in rare refractory cases. And also it should be under the specialist supervision, and we should be like more careful about the various risks, about various thromboembolic risks, various CV risks, and more evidence is needed in this regard. So my practice, I don't use both simultaneously. So I substitute one to other as per the patient profile.
Okay, nice. But unofficially, I think many of nephrologists are using. But yes, real world data is and evidence is much needed in this regard. Excellent. I'll move on to question sets for Dr. Shital. Shital, sir?
Yeah, hi.
Hello, sir. So my question is, so what is your experience with use of ferric pyrophosphate during chronic hemodialysis patients?
Yes, ferric pyrophosphate citrate was initially approved way back in 2015 in US as a novel way of providing iron to especially dialysis patients. We are talking about hemodialysis population. So this is a unique iron preparation which is water soluble and which does not have a carbohydrate moiety. I mean, all the other iron preparations would have some. So, and it was found that this ferric pyrophosphate citrate has got a molecular weight which is similar or close to vitamin B12, and it can easily diffuse across the dialyzer membrane. And considering these properties, in 2015, the US FDA had approved this molecule. It was available, I guess, as triferric, and it was supposed to be given through the dialysate, the bicarbonate component of the dialysate, and it also has a unique way of delivering iron directly to the transferrin. So it sorts of bypasses the reticuloendothelial system and is not interrupted by higher level of hepcidin, especially which are relevant in our dialysis population. So because of these unique properties, this molecule was, I guess, used, and there were quite a couple of trials which looked at using ferric pyrophosphate citrate, delivering it through the dialysate in hemodialysis population. And then it was found that it does replace the conventional iron which is lost during dialysis. So it is a more physiological way of replacing the everyday iron loss which we see in our dialysis population, and does not cause iron overload. So that way it was supposed to be very beneficial. The requirement of ESAs are less. The requirement of IV iron also becomes less if you are giving it as a daily supplement through the dialysate. So this was, I guess, how ferric pyrophosphate citrate was being utilized. But somehow, I guess, a year back, the product was taken off. I mean, I really don't know what was the reason. But I guess since last year or so, this triferric is probably not available for use. But it's a very unique molecule which basically is more physiological way of delivering iron through the dialysate for a dialysis patient. And yes, if probably we had the opportunity of using it, we would definitely consider using it in our dialysis population.
Yes, sir. Rightly said. So I know today's topic is mainly of anemia, but your question is different right now. So what is your choice of modality for treatment of polycythemia in kidney transplant patients? Is it really a phlebotomy, or do you use ACE or ARBs, ACE inhibitors or ARBs?
Okay, so for post-transplant erythrocytosis, my first option would always be starting with an ACE inhibitor or an ARB, and especially if the transplant recipient is coming with a hemoglobin going beyond 17 grams, I would initiate first on, I mean, I prefer using losartan, so that is what I would tell you, that I start with losartan 50 milligrams every day. Obviously, we would monitor the creatinine and potassium every 2 weeks once we start an ARB or an ACE inhibitor, especially in a transplant recipient, because we are all definitely worried about the rise in creatinine or the rise in potassium and those things. So, but if the patient is tolerating, I would start with losartan first, 50 milligrams, and then look at the hematocrit 2 to 4 weeks down the line. If the hematocrit is getting better, and better here meaning getting lower, then I would probably continue with losartan. I would probably go to the maximum of 100 milligrams if the patient's blood pressure tolerates, and if the potassium is not an issue, then I would go up to 100 milligrams and continue it provided that it is stabilizing the hematocrit. Now, for patients where the hematocrit is not coming down, and in spite of giving the optimal dose of ACE or ARB, and the hemoglobin is above 18 grams or going beyond that, then those are the patients where I would advise them to undergo periodic phlebotomy. So I would, sort of ask them to do a phlebotomy of around 500 ml of blood every 2 or 3 weeks till the hematocrit is in a safe range below 51-52%, and then probably continue them on ACE or ARB. So I would begin with an ACE ARB first, and then would consider phlebotomy in patients where they are not responding to ACE ARBs.
Okay. But sir, how frequently you need to restrain to phlebotomy? That means ACE ARBs do.
I guess if I see 10 patients with post-transplant erythrocytosis, then 7 or 8 will do well with an ACE or an ARB. So there will be 1 or 2 patients who may not tolerate or who may not respond to ACE or an ARB, and they are the ones who probably would go in for phlebotomy. So maybe just 10% or maybe 20% maximum would require phlebotomies.
Okay. Thank you, sir. Thank you very much. Now I'll move on to another set of questions for Chafekar, sir. Hello, sir.
Before
Good
that,
evening, sir.
before that, can I ask one question to Dr. Shital?
Yes.
Very nicely explained, sir. I was just amazed by your comment that use of the citrate molecule coupled with coupled with iron in the dialysate will avoid iron overload. Can you just explain it? I mean, that was very amazing. Like what we are giving through IV or oral formulations, we are always worried about iron overload.
Yes.
But when using dialysate as a vehicle for iron administration, we are like avoiding iron overload. Can you just explain that fact? Because that will be very amazing if we are able to practice it in our day-to-day practice.
Yes. So, the molecule ferric pyrophosphate citrate, uh, it basically delivers the complex of pyrophosphate and citrate actually delivers the iron directly to transferrin. So it's taken up by transferrin, and hence the pickup by macrophages and reticular endothelial system is sort of bypassed. And by doing that, you are providing iron directly to the bone marrow for erythropoiesis. And by this mechanism, and it also accounts that the amount which is given, the through dialysate, the quantity was just around 27 milligrams, and factually you are just going to deliver around 6 to 7 milligrams of iron every dialysis. A very small dose, but where it goes and where it works is very important, and that is the reason why it basically was sort of used to sort of replenish the everyday iron loss which we see in dialysis population. So through our dialyzer, through our tubing, whatever blood is sort of left off, that
Right.
5 to 10 milligrams of iron which is lost, you are just replenishing or replenishing that, and that was probably more physiological way of sort of giving it. And as I said, it binds directly to transferrin, it bypasses the reticular endothelial system and macrophages, and hence probably the issues of iron toxicity and iron overload are definitely lessened. And the trials which actually use these molecules, they looked at the ferritin levels in patients who were receiving dialysate iron, and the ferritin level was not disturbed in any ways. There was no rise in ferritin in patients who received dialysate iron. So what it proved was the storages were not really getting affected. It is only the iron which was delivered, which was lost on dialysis, which was replenished. So that was a very unique way of giving iron to those patients. But my surprise was, why was it taken off? Last 1 year, this molecule is not available, and otherwise we would have definitely used it in our hemodialysis population.
Right. That's really amazing. Thank you.
Dr. Sourabh, I think you are muted.
Sorry, I am audible?
Yes,
Yeah,
perfectly.
Yeah. So I'll continue the session with Chafekar, sir. My questions to...
Am I audible?
Yes, sir. You are audible.
Yes, sir.
Okay. Yeah.
So, sir, how do you evaluate anemia in kidney transplant recipient, and how frequently you are required to do a bone marrow biopsy in those patients?
When you want to evaluate the anemia in a kidney transplant recipient, you have to do early on.
I think your voice is breaking, sir. We couldn't hear you properly.
So I think you are muted, sir. Hello?
Chafekar sir, I think you are muted. I think we can go to the common questions now. I think
Okay.
sir has some connectivity issue.
Okay. Uh, so questions to all. How really you means how do you find KDIGO 2025
Can
guidelines?
I?
Yes, sir.
Hello?
Now you are audible. Now you are audible.
Yeah. So there was some disturbance. I don't know. I'm lost. Yeah.
Okay, sir.
Yeah. So am I audible now?
Yes,
Yes,
sir.
sir.
Yes,
Yes.
sir.
Yeah. So therefore, I was trying to tell you that the cause of anemia early on is different as compared to late causes of anemia in transplant recipients. And late causes would include primarily related to graft dysfunction. That is one of the main causes of anemia. It can also be related to a chronic inflammation in transplant recipients due to any cause, for example, infection related. Specifically, we are talking of viruses which can contribute to anemia. For example, parvovirus, cytomegalovirus, BK virus, Epstein-Barr virus, etc. And allograft dysfunction also contributes to this. In addition, of course, the nutritional causes are also carry forward. Now, I must also tell you that we should not forget the drugs which contribute to the anemia. So, for example, you can have the mycophenolate, you can have trimethoprim sulfamethoxazole, you can have valganciclovir, or you can have the other drugs which are used in transplant recipients, which are contributing to anemia. Recently, we had a patient who has developed pancytopenia, specifically neutropenia, which was probably drug-induced post-transplant. So, when you are treating these patients, you have to treat according to the cause, early on or late onset. And of course, you have to rule out viral infections, you have to look at the drug list, you also have to look at the allograft dysfunction, nutritional causes, and chronic inflammation. I think there was a second question, right?
Yes, sir. So how frequently means bone marrow biopsy is required in such a
Yeah.
patient?
So if you can, put your finger on the cause. For example, if you are sure that this is related to some drugs or the viral infection, or if it is related to nutritional causes, then you don't really require further investigations. But in about 10% of patients, many times it's a vexing issue because you have cytopenias, you have anemia, and you don't really know the cause, and you have ruled out all the causes one by one. So in those situations, you may require to do a bone marrow biopsy to find out some occult diseases, or even to find out if there is an occult infection. So even we have found sometimes infections like tuberculosis. After doing a bone marrow biopsy, when we had a very resistant anemia, and we really could not find a cause. So rarely you may require to do a bone marrow biopsy. It's not very common, but I would say that in resistant anemias you may require.
Yes, sir. Sure, sir. And sir, how do you suspect a patient has pure red cell aplasia?
Yeah, so suppose you have a dialysis patient who is on optimum therapy for anemia, as as has been elaborated by Saurabh in his talk. And you have taken care of the nutritional causes, you have taken care of blood loss, you are giving maximum doses of EPO, you are giving the right doses of iron, and in spite of that, you have given large doses of erythropoietin. So, for example, you have to define what is EPO resistance in a patient where the patient is adequately treated for anemia, but the patient is not responding to EPO. Now, there are some references which have said that more than 450 units per kg is the dose which defines EPO resistance, and that dose is required to keep the hemoglobin around 11. So, if the hemoglobin is not reaching 11, even if the EPO dose is more than 450 units per kg given intravenously or 300 units per kg given subcutaneously, then it is defined as EPO resistance. And if you have EPO resistance, then obviously you're going to investigate that patient further. So typically we do anti-EPO antibodies. Sometimes they are positive. And if you have the anti-EPO antibodies, then obviously you can change the formulation of erythropoietin and then try and find out if the patient responds to another formulation. But if the patient has got persistent antibodies, then EPO may not be very, very useful. And then uh, even large doses of erythropoietin are not going to really work for those patients who have anemia. Also, if you want to define EPO resistance, there is something called as erythropoietin resistance index, where it's a basically EPO dose per kg divided by the hemoglobin level. And that is this is a very useful index in practice if you want to diagnose erythropoietin resistance. So coming back to your first part, the PRCA part. So PRCA is pure red cell aplasia. And in some of our dialysis patients, what we have found is that when we found that these patients had EPO resistance or they were not responding to large doses of erythropoietin, then of course you investigate these patients further and you do a bone marrow examination, both aspiration and biopsy, and then you will find that only the red cell series is reduced. So that is pure red cell aplasia. And generally, the causes rarely are related to autoimmune causes in PRCA. Sometimes they are also related to drugs, and sometimes they are also related to viral infection. So, in our patients, if you have a patient of PRCA, then you may have to rule out autoimmunity, you may have to rule out viral infections like parvovirus and some drugs also. So, as far as the PRCA is concerned, if that is diagnosed, it is treated on the lines of an autoimmune disease and it requires immunosuppression.
Sir, but in clinical practice, means as in your practice, in our patients, what is the maximum dose generally you go up to? See, I will go up to this, and then I'll refer to if PHI or something like that.
Yeah, so generally, as Sourabh mentioned, that you can go up to 10,000 units per week, depending on the body weight of the patient. But what I have found is that, if you use large doses of erythropoietin in our patients, we have done a trial where we used 10,000 versus a lower dose. And we found that if you use large doses of erythropoietin, the incidence of hypertension and left ventricular failure because of that is much higher if you use large doses. Surprisingly, the oncologists use very large doses of erythropoietin and still they get away with it, even up to 40,000 units.
Yes,
So
sir.
therefore, in our patients, if anything which is more than 100 to 200 units per kg, then I think you should start suspecting EPO resistance, though the definition is much higher.
Mhm. Sure, sir. Sure, sir.
Yeah.
And sir, how frequently you see a case of HLH in our patients, CKD patients? And is it really more frequent than what is mentioned in the literature, or it's the same?
So HLH per se without CKD, it is not very infrequent. I'm sure that the incidence of HLH is higher, and though as nephrologists we may not see, but if you look at the hematology literature or if you look at the general population, HLH is not so uncommon. But if you're talking specifically about CKD, I have not seen many cases of HLH in patients of CKD because we know the causes of HLH. Now, HLH is generally either genetic, which occurs very early on in life, or it can be secondary to autoimmune causes. And if you have an autoimmune cause, which is common for the kidney disease as well as for the other autoimmune manifestations, then these patients can have HLH. So, for example, if you have a patient of, say, lupus, or if you have a patient of any other autoimmune syndrome or the mixed connective tissue disease, where there is a CKD component also, In that situation, if your ferritin is very high, if you have a pancytopenia, if you have splenomegaly, all these are indicators that there could be HLH. So therefore, uh, only in that subgroup I feel that where there is an autoimmune cause contributing to the CKD, then probably HLH is seen more commonly. But per se, in routine cases of CKD, we don't see much of HLH.
The reason why we had this question up for discussion was
Hmm.
the diagnosis of HLH is based on ferritin levels.
Yes.
And in CKD, when somebody has an anemia, the ferritins are actually on a lower side.
Hmm.
So, is it possible that we underdiagnose HLH in patients with CKD because anemia and HLH both they are hinged on the same biomarker ferritin, which is influenced by the anemia of CKD as well as hemophagocytic lymphohistiocytosis. So
So the
this was the main
yeah.
intention behind
Okay.
asking this question.
Okay. So you are talking about ferritin and its relationship to HLH. But
Yeah.
I feel that, yes, you have to have a very high ferritin level to diagnose HLH. And in our patient, there could be a low ferritin level. But please remember that ferritin is not the only thing for diagnosis of HLH. You should have
Yes.
the other
Absolutely.
indicators also,
Yes.
like
Yes.
say pancytopenia and splenomegaly and other organomegalies, and of course persistent fever in so many patients. So therefore, if you have other indicators like say pancytopenia or if you have organomegaly, and if you have a low ferritin in that situation or not so high ferritin, then probably that's the only situation where you may think that well there could be a hidden HLH. But generally, the ferritin levels in HLH are very high. They are more than 1500 to 2000.
Yes. Yes.
And so therefore that situation we see in our patients only when there is a functional iron deficiency. That means
Yes.
the ferritin is very high and the serum iron is low, and you are not able to utilize the iron from the tissue stores. So
Yes.
therefore, that situation, if you have a ferritin level which is very high,
Yes.
combined with pancytopenia, then probably is a situation where you may think of HLH.
Right. Sir. Right. Sir. Thank you, sir. Thank you.
Thank you, sir. So, last couple of questions, and the questions are open to all. How do you really find this anemia CKD guideline 2025 guidelines from scale of 0 to 10?
We'll start from Dr. Chafekar, sir, actually.
Okay. Yeah. So, as Sourabh mentioned, that the basic structure of the gold guidelines and the new guideline doesn't change. The basic structure remains the same. There are some nuances which are there as far as these guidelines are concerned. And of course, the HIF PHI thing was not there in the past, so that has been addressed here. And including there is some more data on the darbepoetin versus Midsera versus the alpha erythropoietin. So therefore, these guidelines are, I think, quite useful. They are more practical. And if you are asking me on a scale of say 1 to 10, then I would say that well, it could be around 7 as far as I'm concerned. I would score 7 for these guidelines.
And Shital, sir, what's your take?
I guess I would probably continue what Dr. Chafekar has said. This is definitely an evolution from the 2012 guidelines. Obviously, you cannot have a paradigm shift in a disease which has been there for decades together. The science and evolution or progress is going to be quite slow. We are definitely going to be more careful, have more trials before a new molecule will be coming into practice. So obviously, this is going to be an area where there is going to be gradual evolution. But yes, with the newer molecules being available, in spite of, I would say, the newer molecules being available, the focus is still on iron and it is still saying that don't just look at CKD as the cause of anemia, but look at the other causes of anemia before you would say that this is renal anemia. So these things, I guess, will definitely make us more wiser in evaluating and treating our patients. So I would say yes, it is definitely evolution in progress, and we will probably rely more on these guidelines than the previous ones. So I would probably give it a 9 out of 10.
And Saurabh sir?
Sir, actually, I will keep in between both 7 and 9, 8. It's a mature guideline. It is progressive, but it is appropriately cautious. So, two main limitations. One, still we lack long-term outcome data, particularly in the cardiovascular safety of the new agents. And second, the implementation. It varies in different healthcare setups, in low resource settings, in LMICs. So, 8 out of 10, sir.
Okay, sir. Thank you. Point well taken. And now, considering our patients, with respect to Indian perspective, do we need specific Indian guidelines with respect to management of anemia in CKD patients, or we should just carry on whatever KDIGO has?
Yeah. So can I answer that? Yeah.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yeah. So I think that as far as the Western guidelines are concerned, we always have to think of modification to the Indian setting. I don't think that we should follow the Western guidelines per se as it is, because there are so many nuances for the Indian population. So, if you, for example, parallelly, if you take the nutrition guidelines and if you talk of protein restriction, then obviously our situation is slightly different. So, similarly, as far as the anemia guidelines are concerned, we need to look at so many hard endpoints, basically even related to the targets, even related to the nutrition status, even related to the molecules which are being used and the dosages of these molecules. So we do need some India-specific guidelines. We tried to do this exercise a few years ago and try to build up the consensus with a peer group review. And there, the varied opinions were there. For example, the maximum dose of erythropoietin at one time, 10,000 versus routine dose, or even the investigations which are required to establish nutritional deficiency, which are slightly more aggressive in our situation as compared to the West, though they are of course mentioned in the standard guidelines, or the ruling out other factors, as Shital mentioned, that whether we should also start ruling out other causes more seriously when we are treating anemia. So we do need India-specific guidelines, but maybe you can address some few questions which are typical in the Indian scenario and try and answer them and then modify the KDIGO guidelines.
Yes, sir. Thank you, sir. Thank you, Chafekar sir. Thank you, Shital sir. Thank you, Saurabh sir. This was a rich discussion. And really, thank you for taking out time in your busy practice.
Yeah.
Thank you. Thank you
Thank you
all
very much, sir.
participants for joining us.
Thank
I
you for
think I'll
having us.
Thank you,
conclude the
sir.
session here. This was really nice and really rich discussion.
Thank you very much, sir.
Thank you,
Thank you for
everyone.
the
Thank you so much.
invitation
Take
and
care. Take care and good night.
thank you.
Good night,
And
sir.
I think all of us enjoyed the session. Yeah.
Thank you.
Thank you,
Thank
sir.
you so much.
Bye.